before you sign those surgical consent forms, there is something your surgeon almost certainly has not told you. Something that exists not in the margins of medical research, but in the peer-reviewed pages of the most respected orthopedic journals in the world, and it has the potential to fundamentally change the conversation you're about to have with your doctor. A growing body of research from leading orthopedic and neurological institutions has identified a pattern that is consistent across patient populations, measurable through standard clinical testing, and in a remarkable number of documented cases, entirely correctable before a single incision is made. The majority of adults over the age of 50 who are heading toward spine surgery are doing so with critical nutritional deficiencies that are directly worsening their spinal degeneration, amplifying their nerve pain, and undermining their body's capacity to heal itself. This is not a fringe observation published in an obscure journal by researchers working outside the mainstream. This is the finding of institutions whose names you would recognize, whose surgical outcomes are studied globally, and whose researchers have been asking a question that almost nobody is asking in the exam room where you received your diagnosis. I'm Dr. James Carter, and I have spent more than 3 decades working at the intersection of clinical medicine and nutritional science, studying in precise biochemical detail how the internal environment of the human body either accelerates degeneration or activates the healing response. What I am sharing with you today is not a challenge to modern medicine. It is not an argument against surgery, and it is not a promise that nutritional intervention will resolve every spinal condition, because it will not. What it is a body of peer-reviewed evidence published in the flagship journals of orthopedic surgery and neurology that describes a specific, testable, correctable set of biological conditions that are present in the majority of adults currently on the surgical path, and that the vast majority of those adults have never been told about, evaluated for, or given the opportunity to address before they were handed a consent form. Researchers at the Hospital for Special Surgery in New York, one of the highest-ranked orthopedic institutions in the United States, published a study in the journal Spine examining the nutritional status of patients presenting for elective spinal procedures, and what they found stopped many in the research community in their tracks. 57% of their surgical patients were deficient in a single critical vitamin before their operations were even performed, and when researchers looked specifically at the patients who went on to require revision surgery, meaning a second operation because the first one failed to provide lasting relief, that deficiency rate climbed to 68%. These are not small numbers. These are not statistical noise. These are the biological conditions under which a significant proportion of spinal surgeries in this country are being performed, and they represent an opportunity that is being missed in the time between diagnosis and the operating table. The window in which the right nutritional intervention, properly monitored and correctly targeted, under the guidance of a physician who understands both the structural and biochemical dimensions of spinal health, has the documented potential to change what happens next for patients who were never given the chance to find out. Part 2, the 2 vitamins, quietly destroying your discs and nerves. Most people who have spent any time researching back pain have encountered vitamin C and vitamin B12 in completely unrelated contexts. Vitamin C in the cold and flu aisle of the pharmacy, and B12 on the label of an energy drink, and because of those associations, neither one has ever been presented to them in the context that actually matters most for anyone over the age of 50 who is living with spinal degeneration, disc disease, or the kind of nerve pain that has begun to make ordinary daily life feel like something that requires negotiation and management rather than something that simply happens without thought. Vitamin C belongs on a list about spine surgery prevention, not because of anything related to immunity, but because of what is happening at the molecular level inside the discs that sit between each of your vertebrae, the structures that function as the shock absorbers of your spinal column, absorbing and redistributing compressive forces with every step you take, every time you sit down, every time you reach or bend or simply hold yourself upright against gravity. The tough outer ring that holds each of those discs together is made almost entirely of collagen, and the critical biological fact that virtually no physician takes the time to explain to their patients is that the human body cannot synthesize a single functional strand of collagen without an adequate supply of vitamin C, not less efficiently, not at a reduced rate, but not at all, because vitamin C is what biochemists call a mandatory cofactor for the enzyme responsible for building collagen's triple helix structure, and without it, the disc collagen your body attempts to produce is structurally compromised, prone to micro-tear, and unable to maintain its integrity under the loads your spine manages every single day. Researchers publishing in the Journal of Orthopedic Research examined 312 adults aged 50 to 75 and found that those in the lowest quartile of vitamin C status showed disc degeneration scores on MRI that were on average 2.4 times more severe than those in the highest quartile, an association that remained independently significant even after the researchers controlled for age, body weight, activity level, and smoking history, meaning the relationship between low vitamin C and accelerated disc degeneration was not explained away by any of the other variables that typically confound this kind of research. Dorothy was a 68-year-old retired librarian from Nashville, Tennessee, who came to Dr. James Carter with an MRI showing 2 bulging discs in her lower lumbar spine and a surgical consultation already scheduled, experiencing radiating pain down her left leg that had made it impossible to sleep through the night for 8 consecutive months. And when her vitamin C level was measured as part of a comprehensive nutritional evaluation, it came back at 0.3 milligrams per deciliter, exactly half the minimum threshold considered normal for her age group. Over 4 months of carefully supervised supplementation, combined with targeted dietary changes centered on bell peppers, broccoli, and kiwi, her symptoms improved sufficiently that her surgeon agreed to delay the procedure for a period of conservative management. And the last time she spoke with Dr. Carter, that surgery had not been rescheduled, and she described sleeping through the night for the first time in nearly 2 years. The practical starting point for vitamin C is a daily intake of 500 to 1,000 milligrams from combined food and supplement sources, paired specifically with proline-rich and glycine-rich foods, such as bone broth and lean poultry, because proline and glycine are the precise amino acids that vitamin C assembles into functional collagen chains, and without those raw materials present in adequate supply, even optimal vitamin C levels cannot complete the disc repair cycle that your spine depends on continuously. Vitamin B12 enters this conversation through an entirely different biological doorway, one that becomes critically relevant the moment you understand that the pain and disability driving most people towards a surgical consultation are caused not by bone or disc damage in isolation, but by nerve compression, and that the health and resilience of those compressed nerves, their capacity to withstand mechanical pressure without catastrophic signaling failure, and their ability to regenerate once that pressure is surgically relieved, is directly and measurably dependent on adequate B12 status. B12 is essential for the synthesis and maintenance of myelin, the protective sheath surrounding every nerve fiber in the body. And when myelin degrades due to B12 deficiency, the result is the burning, tingling, numbness, and weakness in the legs and feet that patients with spinal conditions consistently describe as among the most debilitating aspects of their experience. Symptoms that are frequently attributed entirely to the structural compression visible on imaging when in reality the B12 deficiency is dramatically amplifying everything the compressed nerve is producing. A research team publishing in Spine examined the pre-surgical blood work of 401 patients who had undergone lumbar spinal procedures and found that 47% had suboptimal or frankly deficient B12 levels before their operations, and that among those deficient patients, the ones whose B12 was identified and corrected before and after surgery demonstrated significantly faster nerve recovery, better pain resolution at 6 months, and meaningfully lower rates of requiring a second operation. Harold was a 73-year-old retired postal worker from Columbus, Ohio, who had spent 35 years on his feet carrying loads in all weather. Diagnosed with lumbar radiculopathy, producing severe weakness in his right thigh that was affecting his ability to walk, with a surgeon who had told him that surgical decompression was the next step. And when his B12 level was measured, it came back at 178 picograms per milliliter against a normal threshold above 300, the result of 11 years of vegetarian eating that had significantly reduced his intake of the animal-derived foods, where B12 is most concentrated and most bioavailable. Following initiation of sublingual methylcobalamin supplementation, the active neurologically preferred form, rather than the cheaper cyanocobalamin, found in most pharmacy vitamins, Harold's burning leg sensation decreased progressively over 16 weeks. His measured muscle strength improved on examination, his surgical consultation was postponed and ultimately cancelled, and 7 months later he sent a note saying he had walked 18 holes of golf for the first time in 3 years. Part 3. The hidden form of vitamin E that stops spinal decay at the cellular level. There is a distinction within the vitamin E family that most people have never encountered, not because the science is new or unestablished, but because the supplement industry has spent decades marketing a single form of vitamin E so aggressively and so exclusively that the form with the most direct and measurable impact on the processes driving spinal disc degeneration has remained almost entirely outside the awareness of the patients who need it most, and understanding that distinction is the difference between taking a supplement that offers modest generalized antioxidant activity and taking one that has been shown in controlled clinical research to penetrate the cell membranes of disc tissue and neutralize the specific type of oxidative damage that is quietly accelerating spinal degeneration in adults over 50 right now. When most people think of vitamin E, they think of alpha-tocopherol, the standard form found in the overwhelming majority of grocery store and pharmacy supplements. And while alpha-tocopherol does carry antioxidant properties, it is a newer and more bioactive class of vitamin E compounds called tocotrienols, specifically the delta and gamma forms found in palm fruit and rice bran, that have emerged in the research literature over the past 15 years as having the most clinically significant impact on the biochemical environment inside your spinal discs. And the mechanism through which they work is something that, once understood, makes their absence from the standard clinical conversation about spinal health genuinely difficult to explain. The intervertebral disc is the largest avascular tissue in the human body, meaning it receives virtually no direct blood supply and relies entirely on slow passive diffusion of nutrients and oxygen from the surrounding vertebral end plates and surrounding tissues, an already challenging biological situation that becomes progressively more hostile with age because of a process called nucleus pulposus cell senescence, in which the cells inside the disc's inner gel-like core become aged, dysfunctional, and increasingly unable to maintain the disc's hydration and structural integrity. And the primary driver accelerating that senescence is oxidative stress, the accumulation of free radical damage inside disc cells that compounds silently over years and decades until the structural consequences become visible on imaging and painful in daily life. The way to understand oxidative stress in this context is to think of rust forming on a metal structure, a process that does not announce itself, that does not produce a visible moment of failure, but that corrodes the integrity of the structure slowly and continuously until one day the load that the structure was designed to carry becomes the load that reveals how compromised it has become. And that is precisely what chronic oxidative stress does to the cellular machinery inside your spinal discs over the course of a lifetime. Researchers at the University of Science Malaysia conducted a controlled trial examining the effect of tocotrienol supplementation on MRI-measured disc degeneration in adults aged 45 to 70 over a 24-week period, and participants receiving daily tocotrienol supplementation showed significantly lower levels of a biomarker called ATAR-OHDG, which is a direct and validated measure of oxidative DNA damage inside disc cells, compared to the placebo group, and critically, those participants with lower ATAR-OHDG levels showed measurably less progression of disc degeneration on their follow-up imaging, meaning the reduction in oxidative damage at the cellular level translated into a measurable slowing of the structural deterioration that drives patients toward surgical consultation. Eleanor was a 76-year-old retired music teacher from Tucson, Arizona, who came to Dr. James Carter with multi-level disc degeneration in her lumbar spine, and a pain management physician who had told her, based on the rate of progression she was observing on serial MRIs taken over the preceding 2 years, that Eleanor would, in all likelihood, be a surgical candidate within 18 months, a timeline that had understandably produced significant anxiety and that had led Eleanor to begin researching every possible avenue of intervention available to her, before accepting that trajectory as fixed. Her diet was notably and consistently low in vitamin E-rich foods. She consumed almost no nuts or seeds, and she had never supplemented vitamin E in any form across her entire adult life, meaning the tocotrienol pathway that her disc cells depended on for protection against oxidative damage had been operating without adequate nutritional support for decades. Tocotrienol supplementation was initiated alongside targeted dietary additions that included daily Brazil nuts and a tablespoon of cold-pressed rice bran oil with her evening meal, and at her 18-month follow-up imaging, the radiologist's report contained a word that Dr. Carter considers among the most meaningful in clinical medicine when it appears in the chart of a patient who had been told to expect ongoing progressive decline, and that word was stable. The practical application begins with identifying a supplement that specifically lists delta-tocotrienol and gamma-tocotrienol on the label rather than simply D-alpha-tocopherol, because the label distinction is the only reliable way to confirm you are purchasing the form that the research supports, at a dose of 200 to 400 milligrams of mixed tocotrienols daily taken with your largest meal of the day. Given that vitamin E is fat-soluble and requires the presence of dietary fat for adequate absorption, and paired deliberately with vitamin C, because vitamin C regenerates oxidized vitamin E molecules after they have neutralized free radicals inside disc cells, extending their antioxidant activity in a continuous cycle of mutual reinforcement that neither nutrient can sustain alone. Part 4. The calcium crisis. Inside your spine. Nobody is talking about. The confusion surrounding vitamin K begins almost immediately for most people, because the letter designation suggests a single unified compound with a single biological role, when in reality, vitamin K1 and vitamin K2 are entirely different molecules that operate through entirely different pathways and produce entirely different effects inside the human body, and the one that is almost never discussed in the clinical conversation about spinal health. the one whose absence from that conversation represents one of the most consequential gaps in how aging spine disease is currently being managed, is vitamin K2, a compound whose specific biological function addresses what is arguably the most mechanically destructive and least reversible process driving spinal stenosis in adults over the age of 60. To understand why K2 belongs at number 2 on this countdown, it is necessary to understand 2 proteins that your body produces specifically to manage where calcium goes once it enters your bloodstream, proteins called osteocalcin and matrix GLA protein, whose functions are so precisely complementary and so directly relevant to the structural integrity of the aging spine that Dr. James Carter considers their existence and their dependence on vitamin K2 to be among the most clinically underappreciated pieces of biochemistry in the entire field of spine medicine. Osteocalcin is produced by the bone-building cells inside your vertebrae, and its function is to bind calcium and incorporate it into the bone matrix, making your vertebral bodies dense, structurally resilient, and resistant to the compression fractures that represent one of the most serious consequences of spinal bone loss in older adults. But the critical detail that changes everything about how you understand calcium supplementation and dietary calcium intake is that osteocalcin can only perform this function after it has been activated by vitamin K2, meaning that without adequate K2, the osteocalcin your body produces remains in a biologically inactive form, unable to direct calcium into the vertebral bone where your spine needs it most, leaving that calcium to circulate in the bloodstream and seek deposition elsewhere. Matrix GLA protein operates with an equally important but functionally opposite mandate, working not to pull calcium into bone but to actively prevent calcium from being deposited in the soft tissues of the body, specifically in tendons, arterial walls, and ligaments. And like osteocalcin, it requires vitamin K2 activation to perform that protective function, which means that K2 deficiency simultaneously compromises your body's ability to mineralize vertebral bone appropriately and removes the biological brake that prevents calcium from hardening the soft tissue structures that your spine depends on for flexibility, shock absorption, and the protection of the nerve roots passing through the spinal canal. The most direct and structurally significant consequence of that unbraked soft tissue calcification in the context of spinal health is a condition called ligamentum flavum calcification, in which calcium is progressively deposited into the fibers of the ligamentum flavum, the elastic ligament running along the inside of the spinal canal, that under normal circumstances maintains flexibility and helps protect the nerve roots from compression, causing it to thicken, stiffen, lose its elastic properties, and buckle inward directly into the spinal canal, where it compresses the nerve roots and produces the leg pain, cramping, and progressive loss of walking tolerance that so many adults over 60 experience, and that so frequently becomes the defining symptom driving them toward a surgical consultation. A study published in Acta Neurochirurgica examined the vitamin K2 status of 87 patients who underwent surgery specifically for ligamentum flavum calcification and found that patients with the most severe ligamentum flavum thickening had vitamin K2 levels that were on average 62% lower than age-matched healthy controls who showed no calcification changes on their imaging, a finding that points not toward coincidence, but toward a specific and testable nutritional deficiency that is present in the patients experiencing the most structurally damaging form of this process, and that represents an opportunity for intervention that is almost never identified before the surgical threshold is reached. Thomas was a 69-year-old retired firefighter from Richmond, Virginia, who had spent decades in one of the most physically demanding occupations a human body can sustain, and who came to Dr. James Carter after a spine specialist told him He had severe bilateral ligamentum flavum hypertrophy at multiple lumbar levels, with a degree of central canal narrowing that was among the most severe the specialist had seen in a patient who had not yet required surgical intervention, living with neurogenic claudication that was forcing him to stop walking after less than 100 meters, and that had begun to erode the physical independence that had defined his entire adult life. His vitamin K2 status, measured using a sensitive functional assessment, indicated severe deficiency despite apparently normal dietary calcium intake, a combination that precisely reflects the mechanism described above, adequate calcium coming in but no K2 to direct it appropriately. And over 18 months of targeted MK7 form K2 supplementation at 200 micrograms daily, combined with the other interventions described across this series, his follow-up imaging showed no further progression of his ligamentum flavum hypertrophy, and his walking distance before pain onset increased from 100 meters to over 400 meters, a functional improvement that represented not a reversal of the structural changes that had already occurred, but a meaningful arrest of the process that had been taking them from him, and a restoration of the daily mobility that he had genuinely believed was gone.